She is the Director of Pediatric Nephrology in 𝐶𝐞𝐜 𝐏 Hospital. And we have always listened to her talks on renal transplant, and it's an absolute delight to listen to her. Over to you, ma'am.
Thank you so much. Thank you. I always say that I'm vertically challenged, and I think one request I'll make to the ISBN CON and the ISOT is to have a step stool for people who are vertically challenged like me. So, all right. So today, I'm following some fantastic. I hope everybody can hear me. Yeah. Hello? Yeah. It's a balance between trying to hear and trying to be seen. I am following in the footsteps of some really wonderful speakers this morning. Thank you, sir. This morning, Dr. Guleria, Dr. Gulati, and of course, Dr. Marks. I just wanted to, before starting my talk, make a small pitch again on the, sort of piggybacking on what Dr. Gulati said. There is a manuscript that we put together that has been accepted for publication day before yesterday, Seminars in Nephrology. And the title of the manuscript is Children Are Not Small Adults, Similarities and Differences in Pediatric Transplant Care in Children. So similarities and differences between adults. It was a huge undertaking, but it was a fantastic one. It was sort of a multinational, if you will. We really had some experts in the field write in their own pieces. So I'd really encourage you to please use that manuscript for all your pediatric transplant needs. Thank you. So today I've been challenged with talking about a topic that we all know happens to all of us, taking care of pediatric patients who've had transplants, but very little has been said. Even in the adult world, we have not had much discussion on this. We all know that the options for patients with end-stage kidney disease is they go from end-stage kidney disease to dialysis to transplant. But the reality is that from transplant, almost all transplants are lost, and a lot of it is lost during the pediatric time itself. And it's such a dilemma as to what we really need to do for these patients who have this failing graft. So in the objectives of my talk will be, we'll define a failing graft, because first of all, if you want to have any recommendations, we need to have some baseline criteria for that. I'll talk about management of immunosuppression, which is probably the biggest question as to what you would do with immunosuppression in these patients. We'll see when we have to consider a transplant nephrectomy. Those questions come up. When do we relist and prepare for the next transplant? A very important part of managing failing graft is the introduction of CKD care, which we are not so good at, because I think we all believe that the transplant's working all right. But there are a lot of nuances to also introducing CKD care in these patients. So again, as part of introduction, despite remarkable advances since 1954, when the first transplants were done, actually the first pediatric transplant was many years later in 1965, actually, in UCLA. It's led to improved graft outcomes, but long-term failure is still quite high. Short-term graft survival, we all can be very happy about. It's over 95%. But if you look at long-term 10-year graft failure, it's about 50%. So 50% of grafts are lost, deceased donor grafts, and about 35% living donor grafts are lost by 10 years. And that is great if you can even get 10 years in a lot of our patients. And as much as 64% of graft failure is attributed to rejection, and all of them had chronic antibody-mediated rejection, which is, of course, a big topic in and of itself for discussion. So coming to failing grafts, I must say that there are absolutely no pediatric guidelines. So all of what I'll be discussing today are sort of brought over from adult guidelines. We definitely kind of need our own guidelines because, again, children are not small adults. I'm making some attempts to have some guidelines, but I think as a society, IPTA, I think we should be tasked with having some more guidelines for our patients because it's different. So the adult guidelines, there are at least 3 big papers that have been written about it, review articles, one in Kidney International, one in 𝐶𝐞𝐜 𝐏 𝐏𝐻 and more recently in May of 2021 from the AJT. So reading all these guidelines, knowing what we know about pediatric transplants, I'm going to make an attempt today to see how we can address this in our pediatric patients. Again, very limited data, and practice patterns are very variable and suboptimal. So let's actually define a failing graft, which is actually one of the hardest things to do. So is it grafts that are having a low allograft function but are stable? Or grafts that are actually having declining function, where there is irreversible and progressive decline in kidney function with anticipated graft survival of not longer than a year. So are these patients who need dialysis within the next year? Or are these patients who've returned to dialysis? What do you do about those patients who have an allograft? So failing really implies a predicted need for dialysis or retransplantation within a relatively short period of time, usually less than a year. And the term failing may also signify that there are other sequelae of kidney failure that are present. So here is the whole spectrum of a failing graft. So you could be detection of graft dysfunction at the first instance, and then not able to reverse that graft dysfunction that you found, so the graft function is declining, and then there is the failing allograft, and then a patient who's returned to dialysis. So it's a whole spectrum. So what do you do with immunosuppression and things like that during that spectrum? The other big question that all of us have is, how do we predict when a graft is going to fail? None of us have a crystal ball that we can look at and say, well, your graft is going to fail within the next year, or you will be able to keep your graft. We can say ballpark, in the next 3 to 4 years, in the next so many years, you will need another transplant. So are there any good objective data for us to use to be able to say when a graft will fail? Right now, what we have is, we have eGFR measurements. Of course, 99%, I think, of us rely on serum creatinine. A small group of transplant physicians look at cystatin C as one of the other markers, and sometimes they use a combination of cystatin C and serum creatinine to get your eGFR measurements. Some physicians will look at proteinuria. So worsening proteinuria means worsening graft function and faster deterioration. Some will do protocol biopsies, histology, looking at like all of your BAMF and IFTA scores. And then now with the immunological markers like DSA and stuff like that, people are trying to predict what will happen to the allograft. But we know that individually each one of them is very, very suboptimal. So the Paris group actually looked at this, and what they said was, again, taken individually, parameters such as eGFR, proteinuria, histology, DSA, none of it is individually enough to predict accuracy. But if you take all of this put together and use the demographic data that you already know, and you put it into a prediction score, which they call the iBox, you may be able to say how long an allograft lasts more reliably. So it's more of an objective data. This has been validated in adults, but definitely not been validated in children. And that's something that our group at Cedars-Sinai is looking at. We're also adding on to this the cell-free DNA and the nanostring technology to be able to say how long grafts will last. So it'll take a couple of, at least 1 or 2 years for us to be able to validate that data, but we're trying to see if that is enough for us to say how long. Because one of the most important questions that parents will ask you is, doctor, how long will my child's transplant last? So what do you say to them? I think the first thing is you take a pause and you're trying to make a guess. So if we can have some objective data like this, maybe we'll be able to say how long grafts last. So that is the first thing in trying to establish protocols for failing grafts. We're not there yet, but. So the big question again is management of immunosuppression. So what do you do for patients with a graft that is going to fail? What do you do in terms of their immunosuppression? That's the most important and complicated aspect in caring for patients with a failing graft, because obviously all of these immunosuppressive drugs you've seen, you've heard, that they are associated with potential risks: infection, malignancy, metabolic, cardiovascular. And so, if you take away these drugs too quickly, then you're risking sensitization and rejection. So on the one hand, while you have these risks, infection, malignancy, metabolic, and cardiovascular, on the other hand, you have all of the downsides to reducing immunosuppression, which is preventing rejection, preventing graft intolerance syndrome, which I'll talk about, and preventing sensitization. So I'm going to give you some broad guidelines as to what you would do. When would you just maintain the same immunosuppression? There are at least 4 reasons to keep the immunosuppression the same and not to reduce. One is, if you have an identified living donor who can donate a kidney to the child within the next couple of months, say within the year at least, when a patient is on the deceased donor list and there is an anticipated short waiting time, the deceased donors you'd never know, but if there's an anticipated short wait time to transplant, obviously when they have other solid organ transplants, so multiple transplants, and when you want to maintain their residual renal function. So if they meet these 4 criteria, I've tried to simplify it as much as possible because it's quite hard, but if you meet these 4 criteria, then there is no need to reduce immunosuppression. The need to reduce immunosuppression, so when would you taper immunosuppression, is patients are not considered for retransplantation for one reason or another. Parents don't want, parental choice, the child is, having severe complications, especially infection and malignancy, or they're on dialysis and, if they're on dialysis, we'll talk about it, and they're not ready for retransplant, then you just, wean their steroids very, very closely and stop their immunosuppression. So just broad guidelines: when do you maintain immunosuppression? When do you taper immunosuppression? And we'll talk about how to taper immunosuppression. It's a little more complicated, but at least these guidelines to begin with. Okay? And of course, cost. If the cost is really formidable, then you would try to taper immunosuppression and hope and pray that if they need another transplant, that they are not going to have rejection or won't be sensitized as much. So immunosuppression reduction strategy, I'm going to tell you about an alternate strategy that has been done in adults: late conversion to belatacept-based immunosuppression. One reason for that is because in children who are non-adherent and you know that they are not going to take the immunosuppression, converting them to belatacept, where you give them a monthly infusion, it may retard the decline by elimination of calcineurin inhibitors. It might improve the acidosis and other metabolic parameters. It definitely prevents the formation of DSAs, but for belatacept, you must be EBV seropositive prior to starting belatacept. Even in the adults, there's ongoing clinical trials using belatacept for a failing graft. I do know that belatacept is not readily available in India, and I just saw that tomorrow there is a talk by an adult transplant physician that's titled "Belatacept and Eculizumab, How Much Longer Do We Have to Wait?" So I'm hoping that if the adult community pushes hard enough, belatacept will come to the market in India, and hopefully it can be used for a select group of pediatric transplant recipients who are EBV seropositive. So this is probably the most important slide that I have for today, and how to reduce immunosuppression. So like I just talked about, this pointer is not so great, but so if you anticipate repeat transplant within 1 year, or there is a reliable living donor, at the time of graft failure, just continue immunosuppression. But if you're having any side effects, consider reducing antimetabolite by 50%. So this is what I said. You maintain immunosuppression if you know that there can be a transplant happening soon, okay? On the other hand, if a patient has active infection or is a high risk for infection, or there's a recurrent infection that's going on, active or high risk of malignancy, and there's absolutely no plan for a repeat transplant, these are the patients in whom you can consider just tapering off immunosuppression. So stop CNI, stop antimetabolite, and reduce prednisone by 1 milligram a month until it's discontinued. In most of our pediatric patients, they are not on any more than 5 milligrams, so within the next 5 months, you should be able to discontinue that. This is where the gray zone is, and I've tried very hard to put together sort of a treatment plan. If patients can get a repeat transplant, but it's not for within a year, there is no living donor, there's a low risk for infection, and you wish to avoid graft intolerance and reduce the risk of sensitization, and you want to preserve residual renal function. So if they meet that criteria, then at the time of graft failure, you can continue CNI but stop the antimetabolite. Again, the CNI is continued because of the risk of graft intolerance syndrome, which I'll talk about in the next few slides. And if you ever have to consider reducing prednisone, reduce it by 1 milligram a month till discontinued. And if it is 3 to 6 months later, try to reduce the CNI by 50% and reduce the prednisone. And if it's more than a year later, stop CNI and continue to reduce the prednisone. So if you are not really interested in preserving residual renal function, then you stop CNI. Again, continue the antimetabolite and reduce it by 50%, slow reduction of the prednisone. And if it's 1 to 2 months later, reduce the antimetabolite by 50%, and 2 to 3 months later, stop the antimetabolite. So again, these are guidelines that I'm trying to put together, and I'm trying to see if it works in my own practice, because that is where sort of the proof of the pudding is. If you believe in it, and if you use it, and you find that it's successful, then you can probably make it a part of the larger guideline. So let's talk about indications for allograft nephrectomy. So the first indication is graft intolerance syndrome. So what are the findings of graft intolerance syndrome? How do you even suspect it? So the common clinical findings are fever, gross hematuria, allograft enlargement and localized edema, and allograft tenderness. And the less common findings are, malaise. They're really fatigued. There's weight loss. You see other markers like thrombocytopenia or erythropoietin-resistant anemia, or elevated inflammatory markers like ESR, CRP, and ferritin. So graft intolerance syndrome is one of the most important indications for allograft nephrectomy. What are the other indications? When the kidney itself is a source of infection. So if you have recurrent transplant pyelonephritis, that is an indication for allograft nephrectomy. Renal vein or renal artery thrombosis is an indication. Graft infarction due to any reason. Dr. Guilherme spoke about, when you do an intraperitoneal transplant, a lot of these times these grafts can actually move, and so you could have graft infarction. Usually seen earlier in transplant, but can be seen later on. We had a child who had actually a graft infarction 10 years after having an intraperitoneal kidney. Severe acute rejection that is non-responsive to pulse steroids, severe anemia, and evidence of chronic inflammation. These are all indications for allograft nephrectomy. I'm sure several of you might ask me, what about BK nephropathy? Is that an indication for transplant nephrectomy? Frankly, it's not indication for transplant nephrectomy unless you have features of graft intolerance syndrome. But just make sure that before you consider retransplantation, that the BK viremia is completely under control, and you have a negative BK PCR before proceeding forward for the next transplant. But BK nephropathy in and of itself is not an indication for allograft nephrectomy. We've had 3 transplants that we did in previous patients who had lost their kidney to BK nephropathy, but have done extremely well with their second transplant. In fact, one of them got a 3rd transplant as well. So what are the potential downsides to allograft nephrectomy, and what are the alternatives? So, if you call a transplant surgeon to do a transplant, they will just hop on and do the next transplant like in a blink of an eye. If you call them to do a transplant nephrectomy, I'm telling you, they will try to turf it off to the next surgeon, or that's what happens to our folks where I am. Because it is very difficult to do a transplant, technically very difficult to do a transplant nephrectomy. We have Dr. Guilherme here who might agree with that. It's because the transplant itself is sort of what they call caked in. There's a lot of adhesions, and it's really, you have to literally yank the kidney off from its casing, from its, from where you've transplanted it. And so it's not a very happy procedure that they will do, because, it's sort of a difficult procedure. And the complication rates are also, pretty high. 5 to 48%, including bleeding, hematoma formation, and infection. So what are the other alternatives to allograft nephrectomy itself? So percutaneous allograft embolization may be an alternative, maybe less mortality and morbidity, but post-embolization inflammatory syndrome can happen. You can manage it with analgesics. Up to 20%, though, require surgical removal for persistent graft intolerance syndrome. Okay, so the other thing that, as a person who talks about desensitization a lot, worries about is the potential downside is development of HLA antibodies. As you may have heard, the transplant sort of acts as a sump, if you will, and so the formation of donor-specific antibodies is supposedly less when you have a transplant in place as opposed to having a transplant nephrectomy. But there are there's very conflicting data in the literature. So when this paper did a systematic review of 12 studies, the levels of PRA ranged from 10 to 55% in patients without allograft nephrectomy compared to 20 to 70% in patients who underwent the procedure. So the jury is still out on that as to whether the incidence of DSA skyrockets after allograft nephrectomy, but that's something that we've oftentimes been concerned about. What about relisting? I can tell you that in the United States, individuals are allowed to be waitlisted and start to gain time once their kidney function is less than 20% per ml. This is for adults. However, there is no such GFR cutoff in pediatrics at all. So we go ahead and list the child for a transplant because they get priority points if they are listed before their 18th birthday. And patients with high PRA, which is greater than 99%, also get priority on the wait list. And I'm quickly going to show you, this is how our criteria goes in the United States. Highly sensitized patients are given priority in all sequences. So all the donors, the highest priority for recipients is for the highly sensitized. The best kidneys, so a lowest KDPI score are the best kidneys. We have a pediatric priority here. So if a pediatric patient is highly sensitized and has pediatric priority, they're really on top of the list and they wait the least amount of time. So we are very quick to list our patients for a second transplant if we know that is coming soon, prior to their 18th birthday, because they do gain time on it. For some reason, the number of patients who are listed for the second transplant after the first transplant, the percentage is really dwindling. The number is sort of remaining the same, but if you look at the total number of transplants performed and what is the percentage of patients who are registered after a failed allograft, that number is decreasing. We don't know whether it's because there's swaps, there is preemptive transplants, but the number of patients who are listed, the percentage is definitely decreasing. And there's a lot of study going on to see why this is happening. And then the last part of my talk is just introduction to CKD care. Just remember, the patient who's been transplanted has chronic kidney disease. Whether you want to believe it or not, they do. And so they do have all the ramifications as their graft fails of chronic kidney disease, like anemia, your bone and mineral metabolism, iron deficiencies, malnutrition. All of those things start to crop up with a failing graft. So pay attention to that and introduce CKD care early. They oftentimes have very suboptimal CKD care. It's more so, I think, in the adult world than in pediatrics, because as pediatric nephrologists, we take care of the whole spectrum. We take care of all of the CKD and dialysis and transplant, but more in the adult world, there are transplant physicians who take care of transplants and maybe nephrologists who come in when the transplant is failing. So I feel maybe I'm biased. We do a better job. We do a better job anyway, so. So patients have generally worse blood pressure control, anemia, lower bicarbonate levels, and higher phosphate levels than patients with native CKD. That's what we need to pay attention to. And they are less likely to undergo appropriate dialysis planning and more often not end up with a central venous catheter for dialysis. So really pay attention to that and introduce CKD care early in these patients. And the dialysis modality really should be individualized. There is no hard and fast rule that these patients need only PD or only hemodialysis. It really needs to be just like you would make the decision prior to their first transplant. So in conclusion, when you have a patient with a failing graft, they definitely need medical and surgical management as well as psychological support. It's very, very hard as a transplant physician to tell a patient that their graft will stop working soon or at a certain period of time. But we have to do that in order to acknowledge, first of all, we have to acknowledge it ourselves, then be able to tell our patients and introduce that CKD care early enough and see if they need conservative care or they need dialysis in preparation, or they need to be made eligible for their next transplant. In conclusion, many patients undergoing transplant ultimately experience loss of grafts. Improving intermediate and long-term graft survival continues to be very important to the transplant community. It's not a one-size-fits-all. One of the things that we over and over learn with our patients is that regardless of protocols, regardless of what you have, it's not one size fits all. There's always sort of nuances. They're not here, they're not there. So you have to try and balance that out in terms of your management. But definitely address psychological issues, address non-adherence prior to the next transplant, and then think about belatacept-based regimens when they come about, and manage immunosuppression based on the risk-benefit and timing of subsequent transplant. One task that we have to sort of, as a group, be able to put together is recognizing how we, whether the things that are done in the adult world, like the iBox, et cetera, whether it will work for our pediatric patients and whether we are able to predict graft outcomes based on that. So we have a lot of things to do, and we can add this to our bucket list, I think. So with that, I'm just going to acknowledge all the people I work with, absolutely terrific group of people, and very importantly to also our patients who have so much faith in us in everything that we do for them. Thank you very much.
Thank you so much for the excellent talk, ma'am.
We have 10 minutes for the Q&A. We can take the questions. Yeah.
So, ma'am, I had some questions to you before we can proceed to the house for the questions. So, suppose if we have a 16-year-old female child who had undergone a living-related allograft transplant, it was ABO compatible 4/6 match, and the child goes on to develop BK virus nephropathy along with acute rejection at maybe 4 months post-transplant. The nadir creatinine after transplant was around 1.2 mg per dl, and that increases to nearly 2.5 mg per dl. But with management, it plateaus at that level. Should we consider this child to be having a failing allograft? Number one. Secondly, when should we start CKD care for this child? Like, when should we start planning for, suppose if they're not affording for another transplant, when should we plan putting a fistula and all those things?
Yeah. Great questions. It sort of almost summarizes my talk, if you will. Yeah, again, if the creatinine is 2.5 and remains at 2.5, then you would say that this is a stable, low allograft function. First of all, I think you have to preserve residual renal function as best as you can. So try not to reduce immunosuppression at that point because you want to preserve residual renal function at that point. But in a child like that, when would you consider them for a retransplant? You would always sort of start thinking about retransplant because eventually this graft is going to fail. So talking to them about living donors, or if you're allowed to relist a child with that GFR, try to relist that child. But I think the most important thing is to see how long you are able to manage that allograft for that period of time. So fistula creation, you all are actually much faster than us in the US with pediatric patients in creating fistulas. But generally, a fistula is considered if their GFR is less than 30 and is continuing to decline. So that's what I would say for fistula care for you.
Thank you so much, ma'am. Any question?
Ma'am, I have a question, ma'am. What is your take on use of everolimus with low-dose TAC in a failing graft in pediatric population?
Very, very nice question. I think, one of the talks that I'm giving at the ISPN-Con is about changing your regular, maintenance immunosuppression. So when would you change from tacrolimus MMF steroids to tacrolimus everolimus steroids, right? So I think that the indication would be that if you have a problem with MMF, so if you're continuing to have recurrent infections, if you're having, you want to reduce the tacrolimus levels for some reason in order to preserve the allograft, you can definitely consider changing over to everolimus. But always remember that any combination that you change to, you have to monitor for development of DSAs and for rejection. Typically, we say, again, without having tailored immunosuppression, typically we say that when you're using the tacrolimus-everolimus combination, the levels need to be kept low for kind of both because they interact with each other. So we generally do TAC levels 3 to 5 and everolimus levels 3 to 5 as well. So monitor that, and of course, make sure that you're not getting either infections or development of DSAs.
Is there a cutoff of creatinine level or the GFR at which you initiate everolimus?
There is no such thing. There is no such thing. It's individual, choice.
Thank you.
I have a question for Steve Marks. Steve, when we were there, so as I said, so this is we have about 10-15 minutes and we can ask question to any of you.
That's fine.
When we were there, at least in Evelina and I think in Gauss also, if you are low risk transplant, we were not giving any induction. So is this change because of the steroid free?
Yeah, so I give basiliximab to low-risk transplants so that we get them off the steroids. So most of our patients only have 5 days of corticosteroid therapy.
And if we are going to keep them on steroid and it's a low risk, then you'd still say that maybe we can get away without any induction?
Yeah, so I think if you're giving maintenance triple immunosuppression with prednisolone, MMF and TAC, then you don't necessarily need the induction agent on top of it. But I want to get the patients off the steroids. The majority of our patients aren't on long-term steroids, so I think basiliximab allows that.
And so how many of your, like a rough estimate, how many of your patients who have initially started as steroid-free end up on steroids, say after 2 years or something like that?
Yeah, so it generally, again, it depends on the management, but when we looked at it, it's about 20%. And the reason is because when patients then develop significant viremia, and we're wanting them to take them off the mycophenolate mofetil, I'll put them on a bit of steroids with the TAC.
Because in India, I don't know about Siddharth, but most of us are not doing steroid-free yet in pediatrics. So that's something we should be maybe thinking of. And the other thing was to both of you, like, do you strongly believe that without TAC, there is no immunosuppression possible? Like, if I stop TAC, there is a high chance of DSA. So TAC should be a part of all immunosuppression?
I think, well, I have a few patients not on TAC, so though I've got a few that are on prednisolone, MMF and everolimus that I've converted over time. And obviously we've got some patients that were on the cradle study that are on very low dose. And when I say low dose, I do have some where the levels are between 2 and 4 because they're so over immunosuppressed. So I think it does depend on the patient, but we do have a few patients not on TAC.
I have a child because of this TAC toxicity, etc. We are only at the moment on steroid and everolimus.
Yeah.
Creatinine is stable, about 1.3. But I'm quite worried that whether we should reintroduce TAC or not. I'm worried about that report saying that without TAC, you have a high chance of DSA.
Yeah, I think with that regimen, you've got a much higher chance. So the question is, could you use as low dose of an anti-proliferative as well?
He starts having diarrhea, etc.
So azathioprine you could use. What do you think?
Yeah, no, absolutely. I think, in general, I feel that the transplants that are done here, because it's mostly living related, they are at a much lower risk of, a lot of the things that we see. They're better HLA matched over here. So you can get away with, having maybe no tacrolimus. But most studies, if it was so easy to get off tacrolimus, I think, the adult studies would have all been successful. One of the very important studies that was done in pediatrics, looking at, steroid withdrawal without the use of, it's a CNI withdrawal protocol. There was a very, very high incidence of PTLD. So looking at that, and also you get a very high incidence of rejection as well. So I think whatever regimen you are using, you have to make sure that you balance the risk of rejection and DSA formation with infections. So
I think individualization is very important because even in pediatric, we try to have that one size fit all.
No. You can't. But, that's all we have right now. So we don't have good markers. Like yesterday, those of you were there for Dr. Sutanthiran's talk. That was a big thing, personalized medicine. We're not there yet because we don't know what to do prior to transplant in order to gauge each patient's immune status in order to give the necessary immunosuppression. So till such time, we've got to use the protocols that we have, and move towards the direction where we can do personalized medicine. That's sort of the goal of transplantation in general. So.
Yeah, this is just responding to what Rajiv mentioned earlier. We experimented, when we had only the innovator brand of cyclosporin with a dual drug protocol in pediatric kidney transplants published in pediatric nephrology. Our 1 year graft survivals are very good, 89%, but at 5 years we are down to 50%. So CNI free withdrawal is really challenging.
Still out there, yes, definitely.
Great talk, Dr. Teshu and Steve. My question for both of you, when we talk about new markers for rejection, have you started using those markers in your routine practice, like cell-free DNA? And
yes, so we were the
ksort?
first. Yes, we were the first group that actually started using cell-free DNA. A small snippet over here. I have the luxury of actually being able to do adult transplants as well as pediatrics at our center. I do about 20% adult transplants, and the rest is all pediatrics because my heart is in pediatrics, really. But a lot of the things that I used in adults almost never come down to pediatrics. And I feel like I'm that little bridge that brings those things that I used. And this was one of them. Because I saw the adults using cell-free DNA, and I really asked, why aren't we using it in pediatrics? It's so much more important to us. We can't rely on the serum creatinine. We need something else. And of course, the answer that you get all the time is, it's not FDA approved for pediatrics. So that's when we said, why don't we take it on as a study? And we got a MOU with the company, and we started doing cell-free DNA in April of 2018. So it's about 6 years now, and we're really doing cell-free DNA in our patients. Of course, there are a lot of questions with cell-free DNA. Cost is very, very formidable, all of those things, but it's really, really helped us diagnose rejection early, before the increase in serum creatinine. So we are able to actually treat these early. I don't know whether it'll eventually translate to longer graft outcomes, but at least we're able to diagnose rejection early, especially in our adolescent patients. So ours was the first publication that came out in December 2020. So.
What about the gene arrays like ksort?
No, but we're doing nanostring. So, our adult transplant program is pretty robust. So we always tag on with them and say, okay, why don't we have our pediatric patients? So right now we're looking at nanostrings where they look at 285 genes and seeing whether it correlates with histology, first of all, and whether we're able to use that. So we're going to be seeing, hopefully not this ATC, but next ATC, where if there's a correlation between cell-free DNA and the nanostrings in order to be able to predict rejection earlier on. Yes. So, yeah.
Steve?
We've also looked at nanostring, and we've also published on donor-derived cell-free DNA, because we developed in-house fetal DNA at University College London, so which became part of standard care, where you can detect circulating fragments of the fetal DNA in the maternal circulation and then diagnose trisomy 21, for example. So we've got our own in-house, and I think the problem in America is that all the kits are really expensive. And when you don't get approval for them and they're expensive, then you either have to decide you're doing it with a trial. And none of the companies want to negotiate with anybody outside America. So we've got our own in-house, which we published as well, looking at across pediatric solid organ transplant recipients. But very often I find that you get markers signaled with an increase in the donor-derived cell-free DNA, but actually what does it mean in the patient? Is it a marker of impending renal allograft dysfunction? Is it a marker of damage in the future? So does it help you delineate from infection versus rejection? And a lot of the studies which are done, which are reported, which show that cell-free DNA, these patients have come in, but they've had obstruction excluded on their ultrasound. They've had their viremia come back as being negative. What we've developed is an in-house cell-free DNA that we can get within 24 hours, and using it together with the other results has been very helpful.
True.
So
there are a lot of questions that need to be answered with cell-free DNA, but yes.
So do you act at the noise, even if your patient is doing well, no proteinuria, a stable graft, and
Absolutely.
you see some
Yes, if we see, so again, piggybacking on what the adults have done, we don't know what the, where we should act, What we have acted on is now the cell-free DNA less than 0.2 is considered completely quiet, it's called a peace of mind score, less than 0.2. But if it goes up to above 1, when we biopsied these patients, 98% of our patients have had acute rejection, even though their creatinines were completely normal, even though they did not have proteinuria. Some of these patients even did not even have DSAs, and they showed evidence of rejection on histology. So that is, that's what we find. But then what about patients who are 0.86 or 0.7? Should we biopsy them? Should we not? So a lot of those unanswered questions with regard to cell-free DNA, I'm sure, things will get teased out. I think cost is a very formidable factor. If cost can come down, I think that's the problem in India. They were trying to introduce cell-free DNA in India, but since patients pick up the cost, it's just very formidable. So I think as the use increases and as we get more answers, cost might decrease and you may be able to use it. But clearly, we need another marker. Serum creatinine cannot be a marker for our pediatric patients, especially small patients getting adult kidneys. The serum creatinine is so off. So, in search for a better marker, I guess.
So I have a quick question. How to optimize tacrolimus level in children with high metabolizers? Because often it's quite challenging to get the achieved tac drop level.
So in our patient population, for those that have low TAT levels, I actually sometimes, the bell's gone, put them on fluconazole as well to try and increase the level. And we find that to be quite helpful in the population. We definitely do see differences in metabolism. And I think, as I said, when I was talking about personalized medicine, is understanding the individual pharmacodynamics and pharmacokinetics. Because as we know in our populations, some patients are on very small doses of TAC and they have very high levels, and some are on very high levels, on high doses, and they have very small levels, so very low levels. And I think what I've done is actually do the area under the curve. So I think sometimes when you're just deriving your data from 12-hour trough tacrolimus levels, you're not seeing that the total exposure of the calcineurin inhibitor is actually quite high. So if patients are being admitted, plus they've got complications, I will do at least 4, if not 5 levels during the 12 hours and then draw the graph and see what the area under the curve is. And that can be very informative to say, with that low 12-hour level, actually their total calcineurin inhibition exposure is high.
Yeah, so we have a kid, he's already on almost 2 years on fluconazole. But still, you're not able to withdraw the fluconazole because once you withdraw that, will keep on track. He's not able to get the drop level. And if in case the dose of tacrolimus, creatinine is keeping off. So you're stuck with that.
So sometimes you can even do, this is like, since I've been in transplant for more than 23 years, I can tell you that at one time we actually did TID TAC dosing, so 3 times a day TAC dosing, and seeing if that can achieve. But again, you just have to be careful about TAC peaks at those stages because you can get into significant nephrotoxicity. So doing the tacrolimus kinetics, like Dr. Marks said, is really useful in your patients, in order to be able to do that. A lot of people will do, your SIP testing and stuff like that to see whether they are high metabolizers or not. But you can use fluconazole. The other drugs that we've used, because we didn't want to use fluconazole for a long time, sometimes you'll have elevated liver function tests with long-term fluconazole, is we've used diltiazem. Because a lot of our patients need antihypertensives anyway, a lot of it, especially the steroid-based patients. So diltiazem is a drug that can control your blood pressure as well. And, so it kills 2 birds with 1 stone when you use diltiazem. That definitely increases your tacrolimus levels. The only thing you need to be very careful about is somebody does not discontinue your diltiazem at some point, because their blood pressures were normal, because you're not using it for blood pressure control. Yes. You're using it for, increasing your TAC levels.
Yes. So we have tried the 8-hourly doses.
I'm really sorry for the interruption.
How are you leveling that? When you're doing the TAC drop level?
We keep the same TAC trough levels.
12 hours?
Yeah.
Okay, thank you.
Thank you. Due to time limitation, we have to end the Q&A.
Thank you so much.
Yes.
Yeah.
Thank you. Thanks
We're
to our
always
speakers.
available, so you can ask us questions.
And thanks to our speakers. I would like to request Dr. Umali to please join us on the dais to present the memento to our chairpersons, Dr. Deblina Dasgupta and Dr. Rohit Rungta. I would like to request our previous chairpersons, Dr. Hemant Kumar and Dr. Pragya Pant, to please join us on the dais to receive the memento. And I request Dr. Stephen DeMarks to please present the memento. I would like to request Dr. Decho Pulyanda to please come on the dais to present the mementos to Dr. Sushmita Banerjee and Dr. Sanjeev Gulati.